It is my great pleasure here to introduce our academic keynote speaker, Professor Resnik from University of Maryland, College Park. He's a professor of computational linguistics and a world-renowned expert on one of the hottest areas in AI, which is natural language processing. Last night I checked that his record has 238 publications with over 17,000 citations. Actually, I look at my Google Scholar page as well. Did the calculation. It will take me 100 years, to catch up with the citations. So it's quite depressing. And besides, being a highly successful scholar, Philip is also highly successful in his entrepreneurial exploration. So he has built a company called CodeWrite and sold it to 3M. And now he's, undisclosed amount of money, right? So now he's building at least 3 other businesses, and the rumors are that one of them got a Series A funding of over $2 billion. That's right. So then besides academic as well as entrepreneurial activities, Philip is also quite active, right? He managing his life, right? He has 2 kids and 2 dogs, and also managed to be a music teacher during Sundays. So I don't know how you manage your life, really. So it's just wonderful. So now let's give one round of applause, to Philip.
Thank you. So first of all, thank you for that way over the top introduction. And as a clarification, I was a technical co-founder of the company that was sold to 3M, which means that the undisclosed sum, for me at least, involved not a neighborhood changing where you live event so much as a sprucing the house up a bit kind of event. And the other stuff that I've done some. I've been fortunate enough to be an advisor to some very successful companies, or companies that are moving in nice directions. An advisor, I don't get a lot more responsibility. So thank you very much for the opportunity to be here today. This is my first time here, and it's been really fantastic. I was wondering, as I was listening to the previous talk, whether it was going to obviate what I had to say, and that's why I had to ask the question that I asked. And I think I still have something left to talk about. So I want to start by emphasizing something that was said yesterday, which is that mental health is a hugely important healthcare problem. If you look at the global burden, just from an economic perspective, never mind the personal perspective, it is up there with cardiovascular diseases, edges it out slightly, and costs more than diabetes and chronic respiratory diseases and cancer combined. In addition, in this country, 115 million people live in federally designated areas where there is an official shortage of mental health care providers, which means that even if people recognize that they needed to get help, which is a big problem, they would have a hard time finding a qualified provider in order to go to. So now there's an enormous potential for technology to help here. This is a survey article, that meta-analysis that got a bunch of attention recently, where the punchline was that with suicidal thoughts and behaviors, there has not been any progress whatsoever in prediction over the course of 50 years. Zero progress. Using the traditional approaches, looking at sort of traditional factors. And they point out at the end that this suggests a need for a shift in focus to machine learning, data-driven kinds of approaches. I'm going to focus on suicide as a topic in this talk, but most of what I'm saying really applies to many other things as well. A really nice example of this is a paper by Coppersmith et al. From roughly a year ago, where they were able to achieve prediction of suicide attempts. And this is actual outcomes data on the basis of people's social media posts. At a rate where in their data set it was 90+% true positives with only 20% false alarms. And if you extrapolate that to a population with a base rate of 6%, apparently fairly typical, their model was captured, when it was making its predictions, 40 to 60% of the people that it was making predictions about as likely to go on to commit suicide actually did, compared to 4 to 6% as the typical rate among clinicians. There's a lot of progress being made. How is this made? I'm not going to do a lot of technical stuff in this talk at all. Just people are familiar with supervised learning. That is the workhorse of these approaches, where you have data, you extract features of some kind from the data, and then you look at the relationship of that to the downstream variables that you're predicting. So if you have somebody writing about their experience their freshman year of college, you might be picking up things like, I don't like going out anymore, I want to sit in my room, I get worn out, exhausted, and so forth. In addition, there are unsupervised methods that help address more nuanced issues. So if you take a look at this, what you can do via the color coding is notice here that things in blue are things related to isolation. Things in red are things related to vegetative symptoms. Things in green are relate to anhedonia, not taking pleasure in things that we used to take advantage of. We did a little bit of work applying unsupervised modeling techniques to this. Using, well, semi-supervised. We used something called a supervised topic model, and what we actually found was that if you use as your dependent variable not suicidality, not depression, but simply big 5 neuroticism score, then you actually pick out a lot of categories, which are defined something like word clusters, interpretable word clusters, that capture things that a clinician looks at and says, ah, yes, this makes sense, and is relevant to the problem. So things that correlate with lower neuroticism scores in college students in this population are things like sports and music and social activities. Things that correlate more with higher degrees of neuroticism, which is often comorbid with depression, are things relating to being tired. You notice I've underlined class here. That's a population more specific aspect that it's pulled out. Somatic symptoms, right? People go to the doctor, they don't say, I'm depressed. They say, my head hurts, I'm itchy, I can't sleep, whatever else it is. You also see indications of stress and population-specific things emerging. So the point that I want to make here is that you have the ability to inductively discover in things that from the raw, I don't want to say raw data, but from the language data. And these techniques also allow you to combine that with top-down knowledge-based information. In Bayesian models, these are often incorporated in the form of Bayesian priors. So you let the model take guidance from what you know, and then that Bayesian prior probability is combined with the information you get from the data set, so that if the priors are wrong, they guide what is discovered, but if it's wrong, the data can outweigh it. That's the beauty of the Bayesian approach. And so you can, in suicide, for example, organize yourself around risk factors, or more recently, suicide crisis syndrome as an approach that people have proposed that distinguishes imminent risk from longer-term risk. So there's huge potential for the technologists to help. But I'm now about to go into what my wife, who's a clinical psychologist, fondly or not less fondly refers to as my data rant. So this chart shows you along the x-axis time. The green line over time is the percentage of papers in the big computational linguistics conferences that took a primarily data-driven statistical approach. What you will see is there was a revolution in the late 80s, early 90s, completely revolutionized the field. Natural language processing led AI in this. Right? All the stuff you're seeing with machine learning, right? We were using big data before it was cool. And by 2008 or so, it had taken over the field. The purple line is the same count, but for the American Medical Informatics Association. And the thing I want you to note is indicated by the red arrows there, right? You see a rise taking place there, a full 10 years behind. Why? Well, let's take a look at research data sets in natural language processing. On the left, you see a lot of, this is just a sampler. The Canadian Hansard's French and English translations of political proceedings, widely used in bootstrap and machine translation. The Enron data set of email, which gets at a lot of issues in computational analysis of relationships among people, other NLP. Twitter, Yahoo Answers with questions, Reddit, and so forth. I want you to pay attention less to the data set and more attention to the numbers. 1.3 million pairs of line text chunks, 1 or 2 million tweets, and so forth. On the right-hand side, a couple of relatively recent clinical data sets for research in natural language processing. 400 manually de-identified clinical notes. right? A synthetic data set of records. Mimic, which was mentioned yesterday, has actually been revolutionizing things, but on this scale, it's still a drop in the bucket. 2 million free text notes from 40,000 patients, all from the same medical center in the same specialty area. So what's the problem? I learned a lot from a conversation with Kim Harding of Johns Hopkins yesterday. The main thing that I learned is I don't know a lot about clinical research, the ecosystem of clinical research. This used to say HIPAA balkanizes research, and I've changed that to technology research, because the thing I do know about is research in AI and natural language processing. And here I would say HIPAA balkanizes technology research. This, if you use Siri or Alexa, or you call up and are talking to some automated agent, you are experiencing the result of literally decades of work where data sets were created and made available for research to researchers that were not on the same team. You didn't have to become a part of a team in order to do the research on the data set. And what you see in this chart is over and over again, you start with an easier data set, performance improves, lower is better. This is the word error rate for speech recognition. It improves. So they go from red speech to larger vocabularies, and then you improve that again. Then you go to a harder problem, broadcast speech, conversational speech, and so forth. The way that progress is made in technology these days, and it's not just language. If you look at the ImageNet work that is very widely known for deep learning, it's the same thing, the Netflix challenge and so forth. The way progress is made is by having large, shared data sets that are accessible to multiple researchers in a wide diversity of settings, all trying to do their best on the same problems. And then they get together for workshops, and they talk about what worked and didn't work. And HIPAA makes that difficult, right? And there's a whole long conversation about, should it really? HIPAA really allows stuff. People don't realize that for whatever the reasons, right, it is very, very difficult to do. And it's ironic because we have people who are perfectly willing to give up all sorts of detailed private data about their lives right now, right? These are, I made these up, but they give an illustration of the sorts of things that are going to the companies there on the left. Somebody doing a search for over-the-counter abortion medicine, signs of dementia, had to put Billy in timeout 5 times today, hashtag ADHD, right? Yay for Xanax, I don't know, I made that one up. My point is that people are giving this information to entities, right, whose governance consists of lawyers whose responsibility is to protect the company and stop them from getting sued, and whose primary responsibility is to improve profit for their shareholders. We have an existing ecosystem in academic research where the governance is provided by IRBs who are officially federally designated to act not in the interests of the academics, the people in the middle, but in the interests of the people who are being studied or involved in the research. And their responsibility is not to profit for their shareholders. It is to, if you Google the term contribution to knowledge, that phrase, you will find the definition of the criteria for PhD programs across the country. That is the criterion. And that is intended, at least in principle. Sure, academics have their own agendas. You got to get the publications, there's the politics and all the rest of it. But at least in principle, by definition, a company's responsibility is to its shareholders. By definition, our responsibility is to society. So, mostly the end of the rant, not completely done. Why is this a problem for language? And the point of the question that I asked earlier. Language data is really hard to de-identify well. If you get de-identification rates of 99.99%, you're left with that 0.01. You multiply that by 10 million records, or 100 million records, the kinds of data that we want to be using, and all of a sudden it's not trivial, right? EHR is a whole other talk. Currently create pressure to avoid language. Doctors being forced to use pick lists and the rest of this stuff because the people who designed these things wanted discrete data and decided the best way to get it was to make people input discrete data. Natural language processing could help solve that problem. by turning unstructured data into discrete data. But it's a vicious cycle. Why? Because how do we develop the techniques that will do that? We need access to the data. And finally, if you know technology graduate students, you know what motivates them, and that the answer is cool problems working with interesting people. And it's just easier to go work on something else in this scenario. An example of this, Regina Barzilay, MacArthur Genius Grant winner at MIT, so no small, person here, gave a talk at the big NLP conference entitled How NLP Can Help Cure Cancer, ? Right? And in that talk, one of the slides she presented was about a student of hers, right, using machine learning techniques and had been working in their research on beer reviews. Why were they working on beer reviews instead of breast cancer data, EHR data? And because it was there. And so we see people going off to Google and Amazon and eBay Labs and all sorts of interesting problems that don't help society necessarily as much as some of these other things because it's there. It's harder to work on the stuff that people in this room are concerned about. So what can we do about it? One interesting aspect, again, I love this because so many aspects of this have come up in other people's talk over the last day or two. This is a chart that I stole, where the little red lines are healthcare interactions of one patient encounters over the course of a year. That's the red lines. The blue lines are their social media posts. So Glenn Coppersmith calls the stuff in between there the clinical white space. The clinical white space is an opportunity to create a window into people's everyday experiences and provides enormously important information, particularly with respect to mental health, because in mental health we don't have the biometric sorts of things that you have. It's not doing a finger stick and measuring some property of their blood. You actually have to understand what's going on with the person. It's not measurable in that same way, right? And so what are people doing? One thing that we've done, and others have done, is to collect data sets. We took the Reddit, which is this very widely used group of communities where people sign up anonymously. I'm going to say anonymously in a qualified way. You get to choose your own anonymous handle. If I wanted to make my anonymous handle Philip.Resnik, College Park, Maryland, I could. So some further de-identification is needed, but it is in principle a public set of publicly available anonymous data that, at least with respect to those handles, is easy to de-identify and can also be de-identified using natural language processing techniques simply by doing things like named entity recognition to mask out names and so forth, right? Now, it's publicly available. That doesn't mean you shouldn't be careful. There's a cottage industry in my field of people who are starting to write papers about ethical use of public data, even though it's public. Just because an IRB says it's okay doesn't mean that's enough necessarily. So there are best practices that are evolving. What we did was we collected the data from the 11,000 or so people who posted on the Suicide Watch discussion forum, which largely involves people reaching out for help and peer support, over the entire life of Reddit, from its initiation up to, I think it was 2016, there was a large data dump that was created. And then we did a random sample down to, well, it's supposed to be 1,000-ish users with an equal number of controls, and the controls excluded people who were posting to mental health forums as well. And we then did annotation of suicide risk for these Suicide Watch postings on a 4-point scale that we derived in consultation with suicidology experts. No risk, low, moderate, and severe risk. And for the first time, to my knowledge, we achieved inter-rater reliability of clinician ratings of suicide risk based on social media data. So this is not in-person interviews, this is not looking at the whole person, this is just on the basis of their posts. How at risk are these people? And crowdsourcers didn't do too badly either, and the crowdsourcers actually tended systematically to err on the side of being too cautious, which is good. So using that, there's a workshop that I helped found in 2014 called Computational Linguistics and Clinical Psychology, designed as a forum to bring together in the trenches clinicians with people like me who are the technologists into a workshop at the same time. As I mentioned, you make progress by having teams work on the same data sets, on the same problems, and then looking at what works and what doesn't work. We did this with this Reddit data set, where the question was, can algorithms assess that 4-point level of risk? And we actually had 3 tasks. I won't go into too much detail here. One, task A, was what I just described. You look only at the postings that may be reaching out for help. By the way, some of those are, I'm reaching out for help for my sister, right? That would be an A, no risk, right? Some of them are, I've been feeling depressed. That would not be a D. It's not a severe imminent risk, and so forth, right? This is a use case for peer support forums, crisis lines, and so forth. We also did something where the real world scenario inspiring it was the same thing, but then all of their other posts on Reddit. So you have access, not only, you know somebody reached out, and you see that they reached out for help, but you also now have everything else that they've posted on Reddit in any forum. Right? So they're writing about football games in a football forum, or they're talking about their kids in a parenting forum or whatever. You have it all, right? And then finally, the hardest problem, of course, which we call screening really, is you don't have the evidence that somebody reached out for help. Can you look at their everyday and detect that there's a problem that they should be flagged? We had a dozen or so teams from around the world participating in this. A couple of highlights of the results were at the upper right. If you simply look at the no risk versus everything else, right? So that's the question of, can we just safely disregard this user altogether? Performance was really good. If you look at the high risk, the two-way split, sort of the severe and moderate risk versus the no or low risk, also pretty good. And if you look at the, is this user in crisis, right? Work needs to be done. On the other hand, given the performance of clinicians on this task, remember, I'm not dissing clinicians, I'm married to a clinical psychologist, but it's really, really hard to get this right? So if you see, 0.69 as a performance measure, you have to compare that to how well clinicians do on this task, and we haven't done that for this specific data set, so I don't have a comparison, but in general, it's a really hard problem. That only got us part of the way. That did not get us to outcomes. It got us to clinician ratings of risk, which is a good step, right? How do you actually get outcomes in a world where, for example, you can't go look for the ICD-10 code that says somebody showed up in an emergency department with a self-inflicted injury? Which would be really nice if we were able to do that. The linkage that was talked about there, right? A really interesting approach, same Glenn Coppersmith, is to the best of my knowledge, a unique data donation platform called Our Data Helps, where if you have somebody who, you lost a loved one to suicide, or you yourself survived a suicide attempt, or you're just a control who wants to help, you can go to this site, go through a very careful consent, not the fine print and an app on your phone for some Facebook app, Cambridge Analytica. You can then consent in, give it the information it needs to retrospectively and prospectively collect your social media posts. This includes your private social media posts. This is important because Facebook is by far still, it's changing for younger people, of course, but the largest platform, and the vast majority of the information you want is actually in private posts. This is fully consented donation of data for research purposes. Right? And in addition, the site will do regular surveys using instruments, HAM-D, the BPRS, whatever it is, right, PHQ-9. It will actually ask you to do this. So it'll do stuff at intake, and then you can get longitudinal data, right? So you have this longitudinal self-report scale data. You have outcomes because you know, if, in the case of suicide, if somebody actually made an attempt or not, because when they signed up, that's information. Is this somebody who made a suicide attempt or not? And you have all of this unstructured data as well. This is the kind of fusion of data that we really want to work with, and this is the data set that was responsible for those results on that ROC curve that I showed you earlier. Right? we have been working with Our Data Helps. We, in this case, being a partnership of me with Deanna Kelly of the Department of Psychiatry at University of Maryland School of Medicine. She runs the schizophrenia clinic. And so we got some seed funding and used a big chunk of it to build a data set where we used the Our Data Helps approach, but recruited heavily from populations where we were likely to be getting folks with psychosis as well as depression. To date, we've got 761 people who did the online piece of this, and 90 of those were brought in for a full, like, many-hour-long clinical evaluation in the clinic, complete with all consented, obviously, IRB approved, all the rest of that, complete with audio and video recording of the clinical interviews so that we can start doing things like looking at the relationships between language and the acoustic signature of what they're saying, facial expressions, and so forth. And so we're just getting started with that. So we've been collecting this data, right? I talked about the sharing part earlier with a public data set, right? The Reddit data set, which is Category 4 exempt in IRB terms, so we can share it. Incidentally, for that data set, even though it is exempt in that sense, nonetheless, I instituted a governance process with the American Association of Suicidology so that people have to apply. I could, as far as the IRB is concerned, just put it out there, right? Instead, what we do, and this was really trying to lay the foundations for future stuff, created a process where people fill out an application, including a required IRB approval from their own institution. And then there is a committee, and you need a certain number of votes on the committee to approve it, and then we give them this data, which is, I think, the right kind of model even for data that is officially publicly available. Right? What about the non-public stuff that I'm talking about with Our Data Helps? Sharing is a real issue there, right? And so I was on sabbatical last year, and I did a bunch of different things, but my main sabbatical project, I had applied to Amazon for some funding, and what I proposed was give me a bunch of money and some AWS credits to build a secure platform for research on sensitive mental health data, like the Our Data Helps data. In other words, PII might be there. Now, by the way, Our Data Helps does run algorithmic de-identification, right? So it is actually really well de-identified. But the idea here is, on this platform, even if it weren't perfectly de-identified or not de-identified at all, it would be okay for PII to exist on this platform. Not PHI, obviously. PII, right? With all suitable approvals. And they liked the idea. Instead of giving me this much money to build it and some credits, they gave me the credits and this much money. And so what I ended up doing was partnering with an organization called NORC at the University of Chicago. It used to stand for National Opinion Research Center. Some people call it NORC. And what NORC used to do was a lot of public opinion research, and now they do a lot of data analytics related work for government agencies and other clients as well. They're a nonprofit called clients. And I connected with the person there who has 12 years ago built and started running and has continuously been running an in-house HIPAA compliant data enclave designed to do exactly the stuff that we're talking about here. But up to that point, using a limited range of tools that you could use, right? So you'd have a version of the statistical software, for example, that would not let data out. Here's the problem. You do machine learning research, you do not want to be handcuffed to some particular tool that somebody built. You want to be able to implement your own code, and you want to be able to use the full range of tools that are available. And so with NORC, we have built a platform hosted on AWS. That's the official shout out for getting the funding, I suppose. That basically does not, there is no way to get the data off the platform. You cannot FTP it, you can't secure copy, you can't open a socket, all the stuff computer scientists will do. You're only getting data off of that as pixels on your screen. Right? That now exists. It's in its testing stages. And we are going to be starting to ramp up, bringing on more test users over the next 2 to 3 or 4 months, using the Reddit data set as our test case to begin with, because if we screwed up and stuff gets out, it's okay. And then bringing in other data, I'm talking with the Our Data Helps folks about the schizophrenia data set, the suicidality data set, I'm speaking with other organizations about the possibility of getting their data on so that we can get researchers to the data rather than disseminating the data out to the researchers, which means that people see that this is okay and are more willing to provide it. Because the problem with a lot of the getting people to provide data is fear. Somebody yesterday talked about indemnification, right? When they were talking about having a lot of data and small startup companies wanting to work with them, right? This makes it, the intent is to make it easier, right? For people to be willing to give the data, for people to get the data, and to put in appropriate governance for using the data. To basically just change the conversation. And what I dearly, dearly want to have happen is the equivalent of this to happen for PHI as well, in a nutshell. That finding a way to say it is possible to do this kind of work securely and ethically and within the confines of this kind of work. I'm going to finish by talking just a little bit about sort of hot off the presses in the sense of like proposal level, right? We're just beginning to do some work on the computer scientist named John Dickerson has been taking, I heard a talk that he gave where he's using this cool multi-arm bandits approach. It's the thing in machine learning, right? You're like pulling on slot machine arms and trying to figure out which machines are the highest payoff. And the math, the computational modeling underlying that is a good way of modeling, trying to figure out which thing you should choose when you've only got so many quarters to put into the machine. It's limited resource exploration in order to figure out what's best. And you have to balance, should I keep plugging things in to try to find out, or should I now hone down on these machines and try to win with those, right? They applied this in the context of interviewing, right? You have a low-cost interview, right? You read somebody's resume. You have a higher cost stage where you maybe have a Skype interview. You can have yet a higher cost stage where you bring them in for a visit, right? And so what they did was use that as their test bed for building this tiered multi-armed bandit approach that's very cool, and showed that for a given level of resource, you can do better, right? So if I only have this much resource, how do I optimize how many people, which people should move from one stage to the next, right? And I went to him after the talk and I said, you may not realize this, but you're in the process of solving my problem. Right? You go ahead and replace the value of the hire, which they validated on Maryland CS admissions data, by the way, and showed that they actually did really well in terms of their modeling, making good predictions. And I said, you replace the value of the hire or the admit with the level of risk associated, and now you're solving my problem. Right? This is the hammer-nail thing. Right? They had a hammer, and I was like, wait a minute, my problem's shaped like a nail. And so what we are exploring, what we are designing and beginning to work on is a similar kind of multi-stage approach, where you have inexpensive things like an algorithm looking at somebody's social media. You have more moderate things like ask the person to, for example, participate in a phone call or an interview with an automated agent, so you're just collecting the data, right? As an example, or getting them to fill out a scale of some kind, right? So there's more cost to the person involved, all the way up to clinician evaluation and so forth, right? And so this kind of, the idea here is a shift in thinking from classifying individuals to looking at populations and figuring out how to prioritize with limited resources. That's the fundamental shift in thinking in the work that we're starting to do. So, takeaways. This matters. And the language matters. There's stuff in the language you can't get anywhere else. We can talk about why this is true for things other than mental health, but it's certainly true for mental health. It is possible to do this ethically and securely, and it's time to stop thinking of it as just a research problem. This staged approach and prioritization, and the Coppersmith classification results that are doing better than doctors. It's time to start thinking, given where it is, recognizing that it is imperfect, what is the right way to start phasing this in to actually deploying it and making it work? And so I'm going to finish with a quote from Jeff Hammerbacher, who was one of the leaders of Facebook's data team in the early days. This is what I said to the students in my lab when I gave a version of this talk. I said the best minds of my generation are thinking about how to make people click ads. That sucks. The people in this room don't suck. And that's what I told my students. I said, don't suck. Thank you.
Very interesting presentation, an exciting presentation. So thank you. Very quick clarification question. I was very curious about the data set from University of Maryland that you mentioned on our data.
The Our Data Helps
yeah.
platform?
Yeah. So how do you track outcomes in that kind of a data set? Because all of it is user generated, people's mental health related data, but can you kind of cross tabulate that with actual outcomes data you're seeing in terms of people landing up in the ER or in the hospital or that kind of stuff?
So here's the current state of play. There are two different data sets I'm talking about. There's the original Our Data Helps data set, which we had no part in, which was focused on primarily on suicide, other things as well. What they have there is for anybody who donated the data, if an attempt was made, if it was successful, and when. And since they're going retrospectively, from the retrospective perspective, you have an outcome. So if you could be working, not knowing what this is, and making predictions, you have an actual outcome. Right? For our data set focused on psychosis and depression, we have people doing self-reports, and so you have the sort of scales of psychotic symptoms and so forth. To some extent, those self-report scales are closer to the kind of data that you would consider the dependent variable you want to be keeping track of. And for 90 people, we brought them into the clinic, and it's not self-report scales, it's the full clinical evaluation scales and so forth. And so we have that data as well, and you have the same thing where you can go backwards, and now we have this information at this point in time. In addition, for our data set, we have prospective data, where they did self-report scales every week for 6 weeks, but then every month for 6 months. And so we can actually look prospectively, and we're very interested in things like changes of mental status and so forth.
Sure. Thank you.
Thank you. That's a good question.
Sure.
Yes?
I thought excellent presentation. Really enjoyed our conversation last night.
Your conversation last night really helped us.
So
Thank
cool.
you.
I love the concept of it, and just a couple of questions, maybe comments. And that is, I embrace too the open science community and data for good. I think the challenge sometimes, which is assumed in the open science community, is that there is shared ethics associated with open data. However, they have not been articulated and standardized. And so therefore we have this lack of cohesive public trust.
Yeah.
So that can be a research all in and of its own to help allow new scientists in the field of open data understand the guardrails that you have to have public trust. And you need to have a measuring stick to determine whether or not your open data system aligns to public trust and open data ethics. What are your thoughts about that, and how do you align that or integrate that as part of your framework?
That is a super question, especially since a lot of well-intentioned people have been screwing up. Things like Samaritan's Radar in the UK, they created a platform where if I'm friends with you, I could monitor I could actually sign up with your Twitter address, and it would alert me if its algorithm thought that you might be at risk. That was shut down after 9 days of public outcry. Wonderfully intentioned, badly executed in terms of the kinds of issues that we're talking about and public trust. So number one, don't be stupid for a lot of these projects. Number two, there is, as I mentioned, a literature that is starting to emerge where there are more comprehensive discussions taking place and people offering guidelines. So Adrian Benton and colleagues, Mark Dredzy at Johns Hopkins was his last author on this paper, which is essentially ethical guidelines, proposed ethical guidelines for social media, for using social media in mental health. And there are, in our project, the application, when you apply for this, even though it's publicly available data set, we require people to have said that they've read that paper and agree to follow the guidelines. that are going to be done there. Those include, for example, things you might not think of, like if you're going to use an example from social media in a slide and a talk, don't use it verbatim, change it so somebody can't just go look it up. Right? The IRB isn't capturing that, but so they are only one of a number of things. The research community is starting to evolve these guidelines, I think the way that we get the commonality, because you're right, people just do what they're going to do, especially students don't necessarily think about it and so forth, is by making sure that we create frameworks where attention to the guidelines, at least in terms of looking at them and acknowledging that you're going to follow them, becomes a requirement for access to the data. I think that's, you simply have to make it a requirement. And in an ideal world, some of this will shift over into the IRBs themselves. And the IRBs themselves will start asking these questions and incorporating it into their thinking too.
So this occurs to me, so one way to triangulate on the data that you're getting from social media posts is at a national level, you can get number of suicides from the CDC down to counties.
Yep.
And if we can geolocate posts in social media to specific areas, one might be able to link social media sentiment or whatever you're extracting through your Amazon Talk or expert evaluations with the actual number of suicides. That would give you another perspective on how predictive social media posts are of actual suicide.
Yeah, that's an excellent idea, and it's actually been explored, at least in part already. I think it was Mark Dredzy at Hopkins who's done a lot of public health stuff with social media, looking specifically, for example, at geographic areas that are closer to military bases, as an example. And others have done county-level kinds of analysis in the context of, I believe, school shootings or other sorts of events like that, looking at reactions and differences in reactions in different areas.
So we have one last question.
I think Susan has a question.
Okay, last two questions.
Thanks, great talk. UK Biobank, notwithstanding, we've had the discussion, at least in some communities, about data that's AI ready, and should we just start again, or is there something that we can salvage? And I would just love to hear your thoughts on that perspective.
Can you say just a little bit more about what that means? Because I'm not familiar either with biobank or the phrase AI ready.
Yeah, so, and this tends to be more in the genomic and the more sort of pathway biological data that it comes in all sorts of flavors with all sorts of ontologies, and just doing anything at scale on AI with that kind of data with not great metadata and or not even consistent data from machines is just too difficult. And what we should do is basically recollect data with the right type of parameters that would allow it for at-scale AI computation.
Right. So I think I understand that. So I think I could be wrong, but I think that the really important issue in the question has to do with what we mean when we talk about collecting data. So data could be AI ready, for example, if you have mapped it to a common standard ontology so that everybody can be using the same thing. And so you can take these various approaches, and you've done kind of a reduction of the data, which helps with scalability and so forth. What I would say, and this came up in the conversation with Kim yesterday actually, is that there is a tension, a trade-off between top-down approaches where you define ahead of time in, say, a theory or hypothesis-driven way, or sometimes just a practical way. I've got SNOMED, so we're going to use SNOMED, whatever it is. There's a trade-off between doing that on the one hand, which has the advantages, I think, that you're raising. Maybe we should just collect this stuff that way. Versus the fact that if you do this in a top-down way, you can miss important things that are available in the data bottom-up. And so there needs, I would say my answer to the question is, throwing away data that's already been collected is nuts. What needs to happen is, particularly in the case of language, is the ability to map from the unstructured data, possibly with some level of not 100% confidence, to structured data sources, but also to use inductive and unsupervised and semi-supervised methods to discover what the top-down things should be asking for in the first place and have a tighter iterative control over that, so that you don't have a piece of medical terminology showing up in radiology reports and still not being in the major ontologies 10 years later. I can give you an example of that.
That is fantastic. Thanks. Really great thoughts, and we'll certainly
so I'm on the evil side of your slide. But also to think about how this can play out in that area.
Yeah.
The challenge with using ethical standards in this area is that you've got no enforcement. You may be able to say, well, you can't get the data again, but if you've let a lot of personally identifiable data out into the world, then just like Cambridge Analytics, you can't undo that. So one of the things that I would suggest is a discussion about looking at legislation that could incorporate some of these emerging ethical areas. I'm also a former staffer for a sitting senator, so I have an outlook for someone who is interested in these areas.
I would love to talk with you because one of the reasons I shifted to the data enclave approach was I came to the conclusion, and these were the exact words I used when I was speaking to somebody about this, I've given up on HIPAA itself. The only way that situation is going to improve is if some senator's kid dies for a reason that is directly attributable to HIPAA. Otherwise, there's going to be no change whatsoever. I've spoken with somebody at HHS who recognized that, they actually said yes, this is definitely an issue, and was sort of willing to have a conversation. But my takeaway from the conversation was the law not going to change, the official guidance also very unlikely to change, and so what was being recommended there was providing, this doesn't solve the legal problem that you're describing, right? But providing the pointers so that people can see in one place, oh, this really is allowed, and kind of turn the volume down on the legal fear that everybody has. In terms of the data getting out kind of scenario that you're describing, people are already giving that data to all of these companies, right? With all of that whole left-hand side of the slide. Sorry if the lawyers came across as two people. And I think there's partly a public relations discussion to be had here about you're giving the data to these folks anyway. Your bank account, everything, it's already there, right? You have already decided to do this. So let's take the same view, the practical view. You made practical trade-offs. And let's take a fresh look with that in mind, and try to find a balanced approach that protects the people who need to be protected, and yet allows for the progress we need in order to serve everybody.
Thank you so much for the thought provoking.
Go ahead.
Yeah. we both thank you. We say the same language, don't we? So,
thank you
so much for the thought provoking.
Such great speakers this morning. Thanks again, and thank you all. We're going to take a 10 to 15 minute break now, reset the room, and start with the